Hello and welcome back. So continuing our discussion about the wrist and hand trauma, and after we talked about the normal anatomy of the wrist and some ligamentous injuries in the previous video, now we are going to talk about the scaphoid fractures. Now, generally speaking, the carpal fractures include the fractures of the carpal bones, but mainly the scaphoid fractures, which account for 75% of all of the carpal fractures. Now, rarely the other carpal bones may fracture, such as the lunate, the triquetrum, the trapezium, the capitate, and the hamate. Now, since the fractures of the other carpal bones are all rare compared to the scaphoid fractures, these fractures can be easily overlooked, and that is why careful examination and X-ray inspection, especially after significant traumatic mechanisms, is important. And if it's still in doubt about a fracture in the wrist, CT or MRI scans are options. Now, scaphoid fractures occur with a significant traumatic mechanisms, which would typically involve a sporting injury or a high energy fall, and that is why it is more common in younger and active individuals. And the scaphoid fracture, if missed, they can lead to morbidity, as the risk of non-union can be high, from 14 to 50% if the fracture is displaced. And with non-union comes the risk of avascular necrosis and arthritis, which lead to disability. Now, if left untreated, the arthritis, deformity, and instability may develop within 5 years, which lead to disability. Now let's talk about the mechanism of injury of the scaphoid in scaphoid fractures. So the scaphoid bone lies in the line of loading between the thumb and the forearm. So it is located here in the line of loading between the thumb and the forearm. So it can fracture in case of axial loading on the wrist, enforced flexion or extension and compression of the wrist. For example, in falls on the outstretched hand. So when there is compression on the bone and some flexion or extension mechanism, that is when the bone fractures. Now, scaphoid fractures occur on 3 anatomical locations on the scaphoid, and those include the distal tubercle, the waist, which account for 65% of all of the scaphoid fractures, and then we have the proximal bowel fractures. So on the X-rays here, the scaphoid fractures occur on the distal tubercle, on the waist, and on the proximal pole. Now, it is very important to understand the scaphoid blood supply. So the scaphoid blood supply arises from the dorsal distal pole via a branch from the radial artery and the superficial palmar arch. So the proximal pole gets its blood supply by retrograde flow from the distal pole backwards. So the proximal pole of the scaphoid is considered to have a poor blood supply and less likely to heal than the distal pole, and that would make the proximal pole having high risk of avascular necrosis. So again, the scaphoid blood supply arises from the dorsal distal pole here, and from a branch from the radial artery and a branch from the superficial palmar arch. And the blood flow goes retrograde to supply the proximal pole here. Now let's move on to talk about the clinical features of a patient presenting with a scaphoid fracture. So the patient present with a wrist pain, and they report some type of injury mechanism like falling on the outstretched hand or getting hit by some type of object. And then we examine the patient wrist, and the examination follows the pattern of look, feel, and move. So on looking, the wrist appearance looks deceptively normal in scaphoid fractures, but if you look closely, you notice fullness in the anatomical snuff box. Now, since we mentioned the anatomical snuff box, let's describe it on this picture here. So the anatomical snuff box here lies between the tendon of the extensor pollicis longus here and the tendon of the abductor pollicis longus and the extensor pollicis brevis here. And this is the anatomical snuff box here. So in scaphoid fractures, you notice filling of this area here due to swelling. Now, an isolated scaphoid fracture will not usually cause any deformity, but deformity may be seen when associated with a dislocation of the carpus, for example, the transscaphoid perilunate fracture dislocation. Now, after you finish looking, now you move on to the feel part of the examination, and on feeling, there is tenderness over the anatomical snuff box. So, if you press with your finger on the anatomical snuff box here, the patient would describe tenderness. And also, there is pain on axial loading on the thumb. So, if you press longitudinally on the thumb of the patient, there would be tenderness also. And there is also pain on pushing the scaphoid tubercle backwards. So if you push the scaphoid tubercle backwards, the patient would also feel pain, and this is more specific for scaphoid fractures. And this finding is more specific for scaphoid fractures than the other findings mentioned here. Now, after you finish looking and feeling, you do the movement. So in scaphoid fractures, there is limitation to wrist movement, and this is usually more pain than stiffness, and there is pain on passive ulnar deviation, and this is highly specific for scaphoid fractures. So you try to ulnarly deviate the patient wrist, and if the patient report pain, this is very specific for scaphoid fractures. On the opposite side, lack of pain on ulnar deviation is highly specific of the absence of scaphoid fracture. So if you ulnarly deviate the patient wrist and the patient didn't report pain, this is highly specific for absence of the scaphoid fracture. Now let's talk about the classification of scaphoid fractures. So they are classified according to the Herbert Fischer classification, and this is the most commonly used classification for these fractures. And the Herbert is a 4-type classification system, and it takes into account the fracture stability and if it was acute or chronic. And the Herbert classification provides a guide to the management of the scaphoid fractures. So classifying the patient scaphoid fracture will help in the management of this fracture. And the Herbert type A and type B are for acute scaphoid fractures, and the type C and D are for chronic scaphoid fractures. So starting with the Herbert type A fractures, so type A is for the acute stable fractures, and type A include type A1 and type A2. Type A1 is for the tuberosity fractures, such as you see in this picture here, and type A2 is for the undisplaced waist fractures. And the Herbert type A fractures are treated conservatively by casting in most cases. Moving on to Herbert type B fractures, so the type B is for the acute unstable fractures, and from the name, unstable means that these fractures are treated with surgery in most cases. And in type B Herbert, we have 5 subtypes. So type 1 is the oblique distal third fracture, like you see here in this picture. And type B2 is for the displaced waist fracture, like you can see in this picture here. And type B3 is the proximal third fracture here. And type B4 is for the fracture dislocation that you see here. And type B5 is for the comminuted fracture of the scaphoid that you see here. Now type C in Herbert classification describes the chronic scaphoid fractures, specifically the delayed union, like you see in this picture here. Now type D in Herbert classification is for the chronic scaphoid fractures also, but this time the type D1 is for the fibrous non-union that you can see here, and type D2 is for the sclerotic non-union that you can see here. And type C and D in Herbert classification are treated by grafting surgery in most cases. Now let's talk about imaging in scaphoid fractures. So the X-rays are the first line investigation modality for scaphoid fractures, and initially 4 standard views are obtained in wrist injuries, and those include posterior-anterior with the wrist in ulnar deviation, and this is called the scaphoid view, and also a lateral view and a semi-pronated oblique view and a semi-supinated oblique view. And all of these views must be carefully examined, and often recent fracture only shows in the oblique views and other views are normal. So while examining the X-rays, you look at the fracture line, you notice if it was transverse or oblique, and you also look at the location of the fracture line, if it was in the waist of the scaphoid, or if it was in the proximal pole or the distal pole, and you also look for displacement, if it was translation, angulation, or shortening. Now, if the fracture line is not visible on initial X-rays, treat the clinical diagnosis. And treating the clinical diagnosis means if the patient have limitation of wrist movement, and also if the injury mechanism was severe, in that case you treat the clinical diagnosis by immobilizing the wrist with a below elbow back slap. And you wait and you repeat the X-rays after 2 weeks, and the fracture line shows after a period of time due to bone resorption and movement. So you repeat the X-rays after 2 weeks to allow the fracture line to become apparent, and then you do the X-rays. Now 15% of scaphoid fractures are not visible on initial X-rays. Other options for imaging include the magnetic resonance imaging, and this is highly sensitive for detecting scaphoid fractures, and also very good in detecting soft tissue injuries such as the scapholunate ligament injury, and the MRI is used initially if the X-rays are normal and the clinical examination highly suggests a fracture, but often it is not available in emergency department. That is why in most hospitals we immobilize the wrist and we wait for 2 weeks to repeat the X-rays and see the fracture line. Now the other modality for imaging in scaphoid fractures is the CT scan, and this is also sensitive for detecting fractures, and it is a suitable alternative for MRI. However, the risks associated with radiation must be considered, and the CT will not identify associated potentially significant soft tissue injuries, unlike the MRI, which will show the soft tissue injuries. Now, here we have an X-ray of a scaphoid fracture. So on the left picture, you notice the fracture line is hardly seen on the x-rays, and this is the initial x-rays taken after the accident. And the right picture here shows an x-ray taken after 2 weeks of the accident, and it shows the fracture line very apparent on the x-rays. And this is a waist fracture of the scaphoid. Now let's talk about the treatment of scaphoid fractures in emergency department. So these fractures are managed according to the pattern of reduce, hold, and exercise. And there is no role for closed reduction in displaced scaphoid fractures. So we move to the next step of holding. So the emergency treatment is all about holding, which is immobilization of the fracture in most cases. And this is usually done by a below elbow back slab or a wrist splint. And the patient is reviewed again after a week in the fracture clinic for assessment and to determine definitive treatment. Now, if the patient is suspected to have a fracture but the x-rays are normal, then the patient is reviewed in the fracture clinic after 2 weeks instead of 1 to allow bone resorption, and the x-rays is repeated. Now let's talk about the definitive treatment. So we already mentioned that the Herbert type A fractures are stable and they are treated conservatively in most cases with casting, and Herbert type B fractures are unstable and they are treated by surgery in most cases, and type C and D are treated with surgery by bone grafting. Now we will explain these in more details. So Herbert type A1 fractures, which are the tuberosity fractures, so these are treated in a cast for 4 to 6 weeks, and non-union is rare in these fractures, but if happens, it requires excision of a small fragment or grafting of a larger fragment. Regarding the Herbert type A2 fractures, which are the undisplaced waist fractures, so these are treated either by casting or by percutaneous fixation. Now casting is the more commonly used option, and 90% of waist fractures heal in a neutral below elbow POP cast, and the thumb doesn't have to be included in the cast, and this is usually for 6 to 8 weeks. After that, the cast is removed and the wrist is examined clinically and radiologically by x-rays to make sure healing is complete. If the wrist is painless and the x-rays is normal, then treatment is complete, but if it's still in doubt, then CT scan is most reliable for confirming union. On the other hand, if tenderness is on examination is present or fracture line still visible on x-rays, then cast is reapplied for further 4 weeks, and after the 4 weeks, if the wrist is painless and the x-ray is normal, then cast is removed and treatment is complete. But if tenderness is present or x-rays showing signs of delayed healing, such as bone resorption and cavitation around the fracture, this means that the fracture is complicated by non-union, and bone grafting and internal fixation is indicated. The other option for treatment of Herbert type A2 fractures, which are the undisplaced waist fractures, is by percutaneous fixation, and this is considered in patients who want faster results, such as the athletes, but impact and heavy load should still be avoided until fracture is fully healed. Percutaneous fixation is done by cannulated screws that are passed through small incisions in front of the scaphoid tubercle. Now let's talk about the definitive treatment of Herbert type B fractures. And we already mentioned that these fractures are most commonly treated by surgery. Now, they can be treated also by casting, but malunion and non-union rates are high, so it is better to reduce the fracture, close if possible, and fix it with a compression screw. And this will improve the union likelihood and reduce time for immobilization. Now remember, the Herbert type B fractures include the oblique distal third fractures, the displaced waist fractures, the proximal third fractures, the fracture dislocations, and the comminuted fractures. Now moving on to talk about the Herbert type C and D, which include the delayed union and non-union of scaphoid fractures, and this is due to either poor blood supply, such as in proximal pole fractures, or displacement of these fractures, such as displaced waist fractures. So in delayed union, the fracture line becomes more apparent and hard border develops in the fracture line, making it seem like an extra carpal bone. And in non-union, cavitation appears on the sides of the fracture. Now in case of non-union of the distal pole and waist fractures, the distal fragment rotate forward and the proximal fragment rotate backwards, giving an appearance of a round scaphoid tubercle, which is called the ring sign on the PA view. And it would also give appearance to dorsally tilted proximal pole and lunate on the lateral view. Now non-union of the proximal pole doesn't lead to malalignment, but it does lead to avascular necrosis because of the poor blood supply. So again, the non-union of the distal pole and waist fractures lead to deformity, while the non-union of the proximal pole lead to avascular necrosis. Now sometimes the patient is seen for the first time after an old wrist sprain and the X-ray shows non-united fracture with sclerosed edges, maybe several years old. And this is a classical case of non-union, and in older patients with low demands or those asymptomatic, non-union may be left untreated if the patient agrees after discussion. Usually 3 to 4 weeks of casting may suffice to make the patient comfortable once again, and no further management is required. But if the patient is young and active, then surgery is required. So in acute stage of scaphoid fractures, by 3 months, it may be obvious if the fracture will unite or not. Surgery should be advised, especially in young patients, because it would reduce the chance of osteoarthritis and disability. Surgical options include bone grafting and fixation with K-wires or screws, and this could be done by open or arthroscopic methods. Now let's talk about the complications of scaphoid fractures, and those include non-union, avascular necrosis, and osteoarthritis. Now we already discussed non-union in details in treatment of Herbert type C and D fractures. Now we will talk about the avascular necrosis and the osteoarthritis. So regarding the avascular necrosis, the proximal fragment in the scaphoid fractures may undergo avascular necrosis, especially in small proximal pole fractures, which are far from the scaphoid blood supply. Because remember, the scaphoid blood supply comes distally and goes back retrograde to supply the proximal pole. Now, although revascularization and union are theoretically possible, but it is unpredictable and may take many years. so surgery is advised. So in surgery for proximal bone fractures, the small proximal bone fragment can be stabilized by a very small screw, and if there is space, a bone graft from the distal radius is inserted and healing is more possible if the graft is attached to an arterial pedicle, or if the fragment is grafted through the arthroscope and stabilized with a fine K-wires. If this fails, the dead fragment can be excised, but the wrist tends to collapse after this procedure and arthritis develops. So a better option would be a proximal row carbectomy to remove the entire proximal row of carpal bones, or a scaphoid excision and four-corner fusion, and that is to remove the scaphoid and fuse the capitate, the hamate, the triquetrum, and the lunate all together. That is all done to improve the functional outcome of the scaphoid fracture. Now, a vascular necrosis, if left untreated, it may lead to scaphoid non-union advanced collapse, which is abbreviated as SNAC. So SNAC is an end-stage condition due to vascular necrosis and often requires salvage surgery in the form of a proximal row carbectomy or a wrist fusion. Finally, let's talk about the osteoarthritis of the wrist in scaphoid fractures. So the non-union or the avascular necrosis may lead to secondary osteoarthritis of the wrist, and if the arthritis is localized to the distal pole, then excising the radial styloid may help, but commonly the arthritis progresses and changes appear in the scaphocapitate joint, then in the capitate lunate joint. So stages of osteoarthritis in scaphoid non-union and avascular necrosis include stage 1, which is radioscaphoid arthritis, then stage 2, which is scaphocapitate arthritis, then stage 3, which is lunocapitate arthritis. And the lunate radius joint is never affected by arthritis, thus allowing salvage procedures such as either a proximal row carbectomy or four-corner fusion. And with that, we reach the end of this video. Thank you guys for watching. Please give us a like, comment your ideas and questions, and subscribe. And if you want to support this work more, you can by joining the channel.